Hi, good morning. My name is Onion Ubaldo, and these are my affiliations. As for my conflicts of interest, I have none. So, the plan of attack for this talk will be the following. I'll do an introduction and the strong iron difference talk, epidemiology of metabolic acidosis in the intensive care unit, the common types of metabolic acidosis in the ICU, the clinical consequences of metabolic acidosis, the management scheme, the role of sodium bicarbonate, the evidence behind it on different types of metabolic acidosis, and renal replacement therapy for metabolic acidosis. The bulk of this talk came from this new article by Yagi et al., plus a couple of other references I threw in. When we talk about acid-base balance, we can categorize them into three disturbances, namely respiratory, metabolic, and mixed. But for the purposes of today's sessions, we'll talk about metabolic alone. Now, there is a difference between acidosis and acidemia. Acidosis pertains to blood levels of either the CO2 or the bicarbonate. But when we talk about acidemia, it refers to how the pH is affected. Metabolic disturbances can be further subcategorized into two, low and high bicarbonate. For the purposes of today's session, we'll focus on low bicarbonate or acidosis. Now, Stewart's acid-base theory tells us that pH is governed by three things: the PCO2, the strong ions, and the weak acids. Strong ions are ions that are fully ionized when they are present in the plasma. Strong cations are the following, which are your sodium, potassium, magnesium, and calcium. Your strong anions are the following, your chloride and lactate. And the weak acids are the following, serum proteins, albumin, and organic phosphate. Now, the difference between the strong cations and the strong anions is what they call the strong ion difference, or the SID. The normal SID is approximately 42 megs per liter. For metabolic acidosis to occur, the SID should decrease, but because a decrease in SID facilitates release of H plus in the solution, which will lead to acidemia. There have been a few epidemiological studies on metabolic acidosis in the ICU. Here's one by Mochizuki et al. That looked at severe versus moderate metabolic acidosis in the ICU. They found out that patients with severe acidosis had an incidence of 1.5%, but an ICU and hospital mortality close to about 50%, meaning almost 1 out of 2 patients will perish. For patients with moderate acidosis, however, the incidence was 8 times higher in the ICU, but hospital mortality significantly dropped, highlighting how the severity of acidosis accompanies a graver prognosis. A study by Hyung et al. Looked at all patients with severe acidosis from whatever reason, whether it be respiratory, metabolic, and or mixed. They saw that the incidence was about 8%. They then removed all patients with acidosis secondary to DKA and saw that the ICU mortality was above 50% for patients with purely metabolic or mixed acidosis. Again, underscoring the weight acidosis brings in terms of mortality as what was previously seen in the previous study. Metabolic acidosis has many types. What most of us are familiar with is the HAGMA versus NAGMA categories. In line with Stewart's theorem, we can also look at it in terms of a decrease or an increase in SID type. The most common form of metabolic acidosis is a decrease in the SID type, which means it's either a decrease in the strong cations or an increase in the strong anions. There are three most common decrease in SID types of metabolic acidosis: DKA, high lactate, and high chloride. DKA is pretty much self-explanatory. There is glycogen breakdown from liver stores and this produces acetate and beta hydroxybutyrate, which are strong anions and produces a decrease in SID. Lactate is a strong anion and is 99% ionized in the blood. An increase in lactate due to hypoperfusion will also lead to SID, will also lead to a decrease in SID and promote metabolic acidosis. Finally, a high chloride level, usually iatrogenic, will also decrease the SID. This has been an area of research in the past few years, with recent RCTs showing contradicting results. Unfortunately, it is beyond the scope of this talk. Now here is a table which shows common fluids used in the ICU and their composition. Over to the leftmost corner, we can see the composition of plasma, which shows a SID of 47.2. As a rule, when we are replacing fluids, we should choose the one which resembles plasma more, or in other words, isotonic, quote unquote, with plasma. If we transfuse fluids which are with a lower SID than plasma, the tendency is to decrease the SID and promote acidosis, and hence acidemia, and vice versa. Highlighted is the SID row of plasma and the various IV fluids used in the ICU. The one that most resembles plasma is plasma light, followed by Ringer's acetate and lactate, then 5% albumin. Normal saline solution, or NSS, has a SID significantly lower than that of plasma and hence may promote acidosis. Again, this is the subject of vehement research the past few years with RCTs coming out, but the contents of which are beyond the scope of this talk. This slide shows the clinical consequences of acidosis in the body. The cardiovascular system and the hemodynamics are the most affected by acidemia. It can start off with a low flow state, such as that with hypotension, or low cardiac output state, which then leads into inadequate cellular respiration. The body or the mitochondria is not used, hence there's no Krebs cycle. The cell reverts to anaerobic respiration. Acid continues to build up, which produces acidosis and acidemia. And your proteins, which usually live in a very significant level of pH in the blood, they get denatured. Cellular function then declines, the acidosis potentiates the low flow state, the pH continues to drop, and the organism expires. If the acidemia is not halted, the effects spiral into a vicious cycle that eventually leads to death. What we need to understand with metabolic acidosis is that it is a syndrome and not a disease entity. It's more of like a symptom rather than anything else. It's driven by a disease process rather than a true problem, and what we need to do actually is to treat the underlying cause. What happens usually is that people tend to give bicarbonate because the bicarbonate is low, and this is the usual management strategy. Not to say that it's right or wrong, but we really need to treat the underlying cause more than anything. Now, the giving of the bicarbonate is hinged on the principle that exogenous bicarbonate is a high SID solution and therefore it will fix the low SID problem. Now, the evidence for bicarbonate use has still been, in my opinion, ambivalent, and it hinges primarily at what outcome we are looking at. This is a systematic review by Fujii et al. That included 12 studies, two of which were RCTs that looked at biochemical and physiological effects of bicarbonate. Here are the 12 studies included. The authors looked at levels of pH, bicarbonate, base excess, carbon dioxide levels, sodium levels, chloride levels, potassium, the anion gap, ionized calcium, and the oxygen levels. The bottom line of the systematic review was that the pH increased, the serum bicarbonate increased, the base excess increased, serum sodium increased, carbon dioxide levels increased, the anion gap decreased, potassium decreased, but did all of these biochemical effects lead to clinically significant outcomes? Now, this was a landmark trial by Yaber et al. Back in 2018 entitled the Bicaricu or the Bicar ICU trial, which was published in The Lancet. So what they did was they enrolled 389 patients with severe acidemia. They excluded patients with DKA and CKD. They divided them into the intervention group versus the control group, and they looked at composite outcomes. But their results show that there was no difference in composite outcomes, but the intervention group did have reduced need for RRT or renal replacement therapy in the ICU. This is the outcome table, which showed a non-statistically significant difference with their primary outcome with the overall population, but showed statistically significant benefit with their pre-specified subgroup of patients with akin 2 to 3. The study also showed signals of benefit in their pre-specified secondary outcome measures, as you can see highlighted there. Now, the bottom line of the study, in terms of clinically significant outcomes, is that treatment with bicarbonate amongst patients with severe acidemia and a SOFA score of more than 4 did not lead to lesser mortalities in 28 days, but when they looked at subgroup of patients with akin 2 to 3, the intervention group did have a statistically significant difference in terms of 28-day mortality and a lesser need for renal replacement therapy. This is another study by Zongheng et al. That looked at patients, septic patients, a total of 1,718 patients with metabolic acidosis and sepsis. It was a retrospective propensity scored matched review. They looked at patients with use of sodium bicarbonate infusion versus that with no use of sodium bicarbonate infusion, and they found out that there was no difference in mortality with the overall population, but the sodium bicarbonate group was associated with improved survival among septic patients with AKI stage 2 to 3 or severe acidosis. They found out that the use of sodium bicarbonate infusion showed some statistically significant difference in two of their pre-specified subgroups, those with AKI stage 2 and a pH of less than 7.2, and those with high lactate and a pH of less than 7.2. But again, no statistically significant signal when the overall population was considered. Now, bicarbonate and DKA, sodium bicarbonate was considered because the assumption was acidosis contributes to insulin resistance. Therefore, if you try and reverse it with sodium bicarbonate, DKA might resolve. However, multiple studies by Duhon and Chua have shown no evidence of clinical significant benefit. Now, in terms of bicarbonate and lactic acidosis, there were two RCTs, both of which were single-centered, that compared saline versus sodium bicarbonate for lactic acidosis or levels of high lactate. Cooper et al. In 1990 showed that sodium bicarbonate increased the pH, but no change in hemodynamic parameters. Mathieu et al. In 1991 showed that sodium bicarbonate increased pH, but also no change in hemodynamic parameters. Now, in terms of bicarbonate and cardiac arrest, observational studies noted that there was an increase and return of spontaneous circulation post cardiac arrest in patients receiving sodium bicarbonate. Listed below are the studies that said so. However, recently, there were studies such as this one by Kawano et al. That tells us differently. They said that in patients with out of hospital cardiac arrest, pre-hospital sodium bicarbonate was associated with a non-survival and poor neurologic recovery, and that this relationship was consistent throughout a range of analytical assumptions and across clinically important subgroups. And these results support current recommendations against the routine use rather, of sodium bicarbonate amongst those with undifferentiated cardiac arrest. Another study by Vukmir et al. Seemed to echo what Kawano et al. Was saying, and they said that we conclude that if any, the most beneficial effect is found in those with arrests of prolonged downtime, about 15 minutes, and caution is warranted if bicarbonate is administered to those of more brief resuscitation delay, because no benefit was achieved and theoretical harm can occur. Finally, for the last topic, when do we dialyze for acidosis? The indications of dialyze are as follows. And this is a list that most of us are familiar with, but I'd like to focus on three big RCTs that investigated timing of dialysis in the ICU. The three big RCTs are the Akiki trial, Ideal ICU, and the START AKI trial. The Akiki trial was by Godri et al. And was published in the New England Journal of Medicine. They had enrolled patients with stage 3 AKI, and more than half of them had septic shock. They randomized them into early and delayed renal replacement therapy strategy. And they found out that there was no survival difference between the two groups. In terms of acidosis, as an indication, 21% of those in the control arm were dialyzed due to intractable metabolic acidosis. Barbar et al. Headed the Ideal ICU trial, which was also published in the New England Journal of Medicine. They enrolled patients with stage 3 AKI and septic shock, and they were also randomized into early versus delayed renal replacement therapy strategies. They found out again that there was no difference in terms of probability of survival between the two groups. In terms of acidosis, 13.4% of those who underwent renal replacement therapy had severe metabolic acidosis as the indication for renal replacement therapy. Finally, the latest trial was the START AKI trial, where the institution I trained in Toronto was a part of. This multi continent RCT enrolled 3,019 patients with AKI and randomized them into accelerated versus standard renal replacement therapy treatment strategies. Again, as with the two previous studies, no difference between the two groups were found, and amongst those who were dialyzed, 16.6% met severe metabolic acidosis criteria for renal replacement therapy. Now, to conclude this talk, I'd like to hammer in a few points. Number one, that acidosis is a syndrome or a symptom. It's not the actual disease that we label. It's a sign that something else is going on. So, what we should do is to vehemently look for the underlying cause, whether it be DKA, whether it be shock, septic, cardiogenic, etc. So, what we can do as intensivists is do an anion gap analysis routinely for patients with metabolic acidosis. You can either use an anion gap coupled with a delta analysis, a gap to gap analysis, to try and figure out what is driving this acidosis. The use of bicarbonate for me is still controversial. Personally, I am ambivalent, but I will use it given the right patient and the right scenario. Right patient, right scenario. Probably not for DKA, but probably for patients with severe metabolic acidosis secondary to septic shock. Um, that's also presenting with AKI with high pressure requirements. But when I use this, I will not think that if I give bicarbonate that they will survive more. I would rather put it in the context that when I give bicarbonate, they would probably need renal replacement therapy less rather than anything else. That's the end of my lecture. Thank you for listening. If you have any questions or comments, you can send me an email and I'll get back to you. Thank you very much.